Hi, everybody. John Chernesky from the Rick Hansen Institute. First things first, just want to acknowledge the partnerships. We've got Matthew Roderick from Unite to Fight Paralysis. We've got Sasha Rabchevsky from the University of Kentucky. Obviously, Spinal Cord Injury BC is our host, and I myself represent the Rick Hansen Institute. So this is a quick overview of what we're going to discuss today. What is research? Give you a basic understanding. Why does it matter to you? Start to talk a little bit about the differences between care-related research and cure-related research. Get into some of the details of how research actually works, where we are now, how you can learn more about the efforts that are going into spinal cord injury research, and I think most importantly is how can you help? So again, I'm going to go quickly because I want to try to allot as much time to Sasha and Matthew as possible. So simple definition of what is research. Any systematic activity undertaken to increase knowledge and the use of this knowledge to devise new applications. It's a pretty broad definition. I think a lot of people think research happens in some far-flung place, behind sealed doors. It's a pretty broad definition, and yeah, let's just move right on. We'll get into what we're talking about today in particular, which is health research, and really it's the way that we advance our understanding of spinal cord injury. It's how we get from these antiquated devices of the past to the modern devices we take for granted today. And it can take a whole variety of forms. It can be anything from interventions like surgical operations, various medicines, bowel and bladder medications, or blood pressure regulation, or neuroprotective drugs, devices such as wheelchairs, or various adaptive equipments, or different therapies, the treatments and rehabilitation therapies that you undertook either in your primary rehab or even as an outpatient. And really, I think another big one that often gets overlooked is systems analysis and understanding how healthcare systems work and how we deliver medicine to ensure that people are achieving optimal outcomes. So that's just a quick little overview of some of the areas of research that are undertaken in spinal cord. And generally speaking, the research falls into two main buckets. There's what we call basic or discovery research, which really is that in a laboratory looking through a microscope at a petri dish, generally done in a preclinical setting, which means it's done either in a petri dish or in animal models. Often what I find is most relevant and interesting to individuals living with spinal cord injury is what we call clinical trials, which is when you start to do research with human subjects being involved. And that can take a variety of different forms. It can be something as simple as a survey or an interview, and analyzing how your life is going or how your body is functioning. You can get into non-invasive procedures, scans, and monitoring of bodily function. You start to get into some of these other things, which tend to add a little bit more risk when you start to get more actual physical involvement. You start testing out new equipment, new devices, and new therapeutic techniques. And you can get into even more intense levels where the risk ramps up when you're trying drugs or surgical interventions or testing out new equipment, new devices that still have yet to be proven for their efficacy or the safety. We talk about the difference between a care and a cure. There's research that's being undertaken all the time to try to improve the lives of people with spinal cord injury. It's a question of what can we do right now? How can we help improve your life as it is right now, to improve normalization of blood pressure, to reduce the incidence of pressure injuries, to figure out what therapeutic intervention or physiotherapy interventions going to optimize your recovery after injury. And these things are important. You know, they help to ensure that people can live an optimal life in the now. But that's not where we finish. The ultimate goal for a lot of us is to reverse paralysis, to create neural recovery and allow the spinal cord to function in a normative way. But that's not the only cure. You know, just getting up and walking sounds fantastic, but if I can get my bowel function back normal, like my bladder function to be normal, you know, I know for Teri, blood pressure regulation is a constant issue. The low blood pressure that comes with higher tetraplegia, you know, these are cures. If we can, you know, reduce pain or reduce spasticity, to me, that's a cure. I think that the definition of what a cure is varies from person to person, and perhaps maybe Sasha or Matthew later can elaborate a bit more on it. But I just wanted to let you guys know that when we talk about care versus cure, I think about care as being as work to optimize your situation as it currently is, and cures are looking at ways of improving your neurological function, no matter how small that may be or how significant that may be. So why do we need cures? Because that's what's happening to our spinal cord. That's a little image, a cross section of what a spinal cord actually looks like when it gets damaged, if you guys are really aware of what's happening biologically. So generally speaking, nobody severs their spinal cord. The only time you sever your spinal cord is if something actually protrudes through it. For the most part, it's what they call a contusion injury or bruise, which leads to a scarring in the spinal cord where the nerves can't grow through. The scar blocks the transmission pathway of the spinal cord, the nerves can't grow through, and suddenly your brain and your body are disconnected. So, quick overview of some of these curative interventions that some researchers are working and directions they're working on. One is to stop the scarring and the damage from happening in the first place. These are what we call neuroprotective drugs. The idea is if we intervene with some sort of medicine in the immediate aftermath of a spinal cord injury, potentially we can stop that cascading of events that causes the damage and the permanent paralysis to happen in the first place. Again, highly relevant to somebody who had an accident 5 seconds ago, not quite as relevant to somebody who's had a spinal cord injury 5 years ago. Another area is where they talk about debridement or removing of the scar. If you've ever had a significant pressure injury, you'll know all about debridement. The idea is to remove the scar tissue. But again, you can't just go in there with a scrub brush or a scalpel and peel away at that scar tissue. You need to do it in a bit more delicate ways. So there's a couple of areas of research that are looking into ways of reducing that scarring in the spinal cord. Two key areas, and I think Matthew or Sasha can elaborate on this a bit more, is the use of drugs like chondroitinase or intracellular sigma peptides to try to reduce that scarring to allow those neurons to pass through the scar tissue. Another idea is the idea of a spinal scaffold, basically inserting a biological or a material that can be broken down and create a positive host environment, almost like if you were to put up a trestle for your grapevines to grow. The idea is that you would insert this into the spinal cord and it would create a pathway for neurons to grow through that area where the scar once was. Of course, everybody talks about stem cells. You know, stem cells have the potential to do amazing things, but it's not as simple as just throwing a bunch of cells in there and watching them grow. Again, I'm not an expert in this particular subject, so I'm going to defer to Matthew and Sasha to get into a bit more detail. But suffice it to say is a stem cell can differentiate into just about any particular type of cell. It can become a blood cell, it can become a bone cell, it can become a liver cell. what we need are neurons in our spinal cord, and not just neurons. We need particular neural cells. We need astrocytes, oligodendrocytes. Again, I don't want to put my foot in my mouth, so I'm going to defer to Matthew and Sasha, who I think will elaborate on this a little bit further as we go along. But yeah, sorry, I'm losing my train of thought there. Other things, the devices like exoskeletons, getting yourself up and mobile again, getting out of a wheelchair, getting your body into a normal, the human body is not designed to be sitting all the time. Evolutionary development has gotten us into a bipedal modal. We're meant to stand up, and that allows our organs to sit in a natural position, to move in a natural position. So devices like exoskeletons can increase our mobility and allow our body to operate in a more normalized position. Again, the devices that are on the market currently are really only for therapeutic uses. They're not terribly functional. They don't work in the real world. They're great at walking in a straight line on a flat surface, but as soon as you start to talk about moving in an uneven area, in an uncontrolled environment, they sort of fall flat. So there are second generation exoskeletons that are in development that might potentially have the ability to walk in off-road undulating surfaces. And it's an interesting area of work that's being undertaken. So definitely an area to keep an eye on. This is another very interesting area, perhaps in the near term, provides the greatest potential right now. What we're calling spinal stimulation, either done, they say, epidurally or transcutaneously. Epidural meaning on the dura, so it's an invasive procedure where they insert an electrode onto your spinal cord and then electrically stimulate the spinal cord. Transcutaneous version works in a very similar way, but is done externally, where it's just placed on the skin. Believe it or not, something as simple as this has been shown to improve autonomic functions, mobility, bowel, bladder functions. So again, I think Matthew and Sasha will probably go into a bit more detail than I will on this. But yeah, highly interesting area of research. So I don't know, I'm trying to think about where I'm going with this conversation. Oh, I'd like to make you guys aware of some of the research that's happening and let you know what's currently being undertaken in the field of spinal cord injury research. And the whole reason I'm telling you is because I want you to get involved. And the benefits of being involved, the list goes on and on, but some of the quickest ones is that you get access to the newest technology. You get an opportunity to learn more about your body and how spinal cord injury has affected you. By participating in the research, you're helping to advance the science as a participant. But it's not just about being a participant or being a research subject. The more knowledge you garner, the more you start to understand the science behind spinal cord injury and the work that's being done around it, the more you can start to influence it and inform the research and ensure that it's relevant to you and moving in a direction that's going to take us towards those curative interventions. And then, obviously the philanthropic method or idea that, your efforts today that may not benefit you in the immediate future could potentially benefit somebody who may have a spinal cord injury in the future. Again, I don't want to tell you that it's all sunshine and roses. There are risks involved. If you want to be involved in research, it's work. It's not simple. You know, it takes a bit of effort to get involved, even if you're just going to be a participant. You know, the reason we do the research is to discover what works and what doesn't work. And sometimes there are unintended or adverse effects that can lead to pain, injury, spasticity, autonomic dysfunctions. You know, depending on how invasive the procedure is, you could get infections or even potentially, you know, when you're thinking about some of these highly invasive curative interventions, you might regain function, you might lose function. So you need to be aware of these risks and take that into consideration. So before I pass on to Sasha and Matthew, as I said, I was trying to go quite rapidly here, and so I feel like you might be getting a bit bombarded with information. What does this all mean to you? You know, stay informed. There's plenty of information available to you to get yourself educated on what's happening in research and find ways to gather that knowledge. We'll talk about that a bit later on. Understand that there are risks involved, that your participation is important, and that you should get involved. This matters to you. If you're living with a spinal cord injury, this research matters to you. If you just want to sit around and wait for this cures to come to you, you're not going to help the process speed itself along. You're not going to expedite this process. You're just going to lay on the couch. It might get to you, or it might not. If you want to see spinal cord injury research and curative interventions improve, become the change that you want to see. Get involved, get off the couch, get educated. Yeah. Anyways, that's all from me. I'm going to pass it on to the real experts now. Thank you.
Thanks, John. One thing you forgot is to introduce yourself.
Oh, sorry about that. Let me stop my share here.
You did great. You did great. That was 20 minutes bang on. So that's the allotted amount of time. So I will open up to questions for John, but just I wanted to like share maybe just some of the things that I got from what you were saying, John. And one of them is like, I can say in my experience, I participated in hundreds of studies, right? Over the many years. I've been in a chair myself for, 22 years. And I always thought cure also meant like getting up and walking, right? And for me, I'm like, how the heck are they ever going to get me walking? Like, why should I care about that? But yes, you're right. Like, my blood pressure really affects my daily life, like my, sexual function, the way I, have to find, like, I have to, do where I go to the bathroom, like, and have to plan all around that. That stuff is curative as well. And so when I kind of changed that, it made me participate differently in the research, which then in turn allowed me, now I feel like I have so much more knowledge of research that now I'm able to contribute in the development and the analysis of that research, which is also really interesting. And it's really exciting, and it makes it so much more worthwhile, right?
Yeah, I totally agree with you, Teri. I think that, the simple act of volunteering to participate in research studies is a really great gateway to becoming more knowledgeable about research and starting to understand the processes that are involved. And once you've participated in a few studies, you get to know a few researchers, you start to see from the inside how you can start to influence the research. I think, Matthew will probably talk about that a little bit later in his presentation, but the key first step is to get an understanding of how research works and understanding the science behind the research. But certainly the end goal is increasing the influence that people living with spinal cord injury can have on research.
Right. And the other thing too, if people wanted to be more involved in research, do you want to share where here in BC they can look for that?
Yeah, absolutely. If you live in the Lower Mainland, obviously the Blessing Spinal Cord Center, which is home to iCord, is certainly a great location. Doors are always open here. You can come in and learn. You can check on their website. It's the International Collaboration on Repair Discoveries. I work at the Rick Hansen Institute. We obviously have a variety of research studies that we support and are undertaking. Our partners at Spinal Cord Injury BC also promote research and discuss some of the research that's going on. Those are certainly the first places I would look. Again, not all research needs to be done in person. If you live in a remote area, you can do things like surveys or phone interviews. At home, often researchers will come to you. You don't need to come to them. But certainly, you could either get in contact with either Teri or myself, and we'd be happy to share more information with you.
Awesome. Thank you. Does anyone have any questions for John? I've sort of unmuted everybody, so feel free to unmute yourself if you have muted yourself and have any questions initially. No, I see you talking, Robert, but I can't hear you.
Yeah, I'm just saying, unfortunately, I guess the reality is I talk to myself. Yeah, it was just checking the mute like you're saying.
Okay, perfect. Okay, good. So if no one has any questions specifically for John, maybe later, I'm going to move on to Sasha. I'm just going to mute everybody again and then unmute Sasha. Sasha, right? There you go. So Sasha, don't forget to introduce yourself.
Okay. I'm Sasha Rabchevsky. I'm a professor of physiology at the University of Kentucky in Lexington, Kentucky. I am paraplegic. I'm a T5 complete paraplegic. I have been so since 1985. I was in a motorcycle accident. And not too terribly long after that, when I recovered and went back to school, I decided I wanted to go back to either medical school or research to study spinal cord injury. And so 33 years later, I'm doing that, not only, as I'll be discussing, from a basic standpoint, basic science standpoint, doing research in a laboratory, but for many years, I'm also been a guinea pig. I have electrical implants I have in my legs, in my back, and my butt, which they're called functional electrical stimulation. I'll explain that in a little bit. I guess I wear many different hats, if you were to say. Matthew tends to refer to me as an anomaly, which I take pride in. There's not too many people with spinal cord injuries that are doing research in the spinal cord injury research field. And I guess that's a good segue to begin with what John was trying to explain, is that when I got my implants, which I'll describe now, back in 2002, when I was paralyzed in 85, I had gotten surface stimulation on my legs to ride a FES bike, or functional electrical stimulation bike. I don't know how many of you have heard of those, but it increases circulation, increased muscle mass, and this was again back in the late 80s, 1980s. And I loved it, and it increased my muscle mass, but I was kind of disgruntled after the study was over. It was a 6-week study. They said, well, we don't really have the technology for you. We want you to use it at home, and if you did, it would be expensive. Well, long story short, when I moved to Lexington in 2002, I got involved in a program where I have functional electrical implants. I went to Case Western Reserve in Cleveland, where they have a special program there dedicated specifically to trials, their clinical trials. So I'm still a guinea pig. I got these implanted in 2002, and they're still functioning. I still use them. But I guess the point that I'm going to keep driving back is that I wasn't the Homer Simpson, and not to suggest that other people are, but I was an activist. I wanted to become really active, and no biological solutions were on the horizon then. Perhaps now there are more possibilities, but I wanted to say, okay, I want to walk and I want to stand, I want to move about. So I went and I got a pretty invasive procedure using electrical implants. They're a little bit different than from what John was describing earlier, which are the epidural stimulation. That's a new wave technology that is not as invasive as far as getting into your skin and muscles to stimulate your muscles to contract. But it is the same principle in the sense of what we like to term neuromodulation. We're changing the way whatever is still remains, we're activating it. And we're able to, in some cases, control them very well with electrodes that are strategically placed. Or, like John was describing, the epidural stimulation is very interesting. A lot of people are fascinated because when you do it, things happen. The problem is that you can't really predict what happens. Some patients don't get any recovery. Some patients get some kind of movements. They can volitionally think about movements, but they can't stand and walk. Some people, as John also referred to, get extraordinary recovery of bowel and bladder function or sexual functions, which are typically not the things that you think about when you think about a cure for spinal cord injury. But that in and of itself is where a distinction also comes about with the kind of implants that I have versus the epidural. Is that the implants I have are pretty much you push a button and you know you can make your leg or arm or any muscle group that's innervated to contract and to move. And so you can exercise and do this things. With the epidural, it's a lot of trial and tribulation where they put these implants into the spine and they stimulate, sometimes in conjunction with walking on treadmills. But for the most part, it's very new, and which is why it's exciting, because the potential is huge. But here's where the problem, for me, as I see it, is for our community, our spinal cord injury community. If it's not for individuals that go up and say, I am willing to sacrifice, not my life, so to speak, but my livelihood by getting into a trial and going and being diligent and to properly take notes and do all this stuff. By the way, I'm now 2002 is when I got my implants. It's now 2018. I'm still having to report on a regular basis what the results are from mine. And in doing that, what I start to do is I start to feel like I'm preaching to people. And when I say people, my fellow spinal cord injured folks. And what I'm preaching is that, well, look, I wasn't going to wait around for a cure or a thing to be handed to me. I took what was available and made it better. At least I think I am, and the other people that are involved with it. And so now when you've heard these things that John's been talking about, the epidural stimulation, that's where I think I'm already past my expiration date as far as I'm concerned, as far as trying out new techniques. But it open up the world for people who, with chronic injuries or new injuries, can say, you know what, I'd like to participate in this. And just the mere act of participation does volumes for the movement. Because one of the hardest things, and it's crazy because you think, well, why aren't there more clinical trials? There are many clinical trials out there. They're just not all designed to make you walk again. And so when people kind of go on to even the NIH or National Institute reporter to find out what kind of trials have been done, well, they'll look for walking trials or running trials or even arm. There aren't that many. But if you go looking for spasticity or hypertension or bowel and bladder, there's many studies going on. And so I'm trying to balance this talk after John's really good introduction as to why I'm biased and why I'm so passionate about getting patient and community involvement is because ultimately the researchers, myself included, are waiting to be kind of told what to do by the community, because we have our ideas. I think I want to be able to do this. I think I should be able to make this rat or mouse walk better. But wait a minute, what does that have to do with the persons that are on this call, for instance? How is it going to benefit us? And moreover, how do we inquire whether your research is any good? How do we judge? I'm a layperson. I live in Saskatchewan. How am I going to tell what the work is being done down in, for instance, in Louisville with the epidural stimulation? So I don't want to sound like a preacher, but I really think that getting the word out about the fact that there is research, and we're really trying, and I'll kind of dovetail into this towards the end of my talk, dovetail into networking all across North America. These ideas that are going on at the Rick Hansen, at the University of Kentucky, at the Unite to Fight Paralysis and the Working to Walk symposiums. What are they doing, and how come I'm not getting more information from them? Or in our end, being on the board of some of these, how can we better disseminate this information? So I guess participation and inclusion comes with only after you find out that these things exist. And that's part of a big movement that we're trying to do, and why I graciously was offered and graciously accepted this ability to talk to you guys, is because without voice and without any kind of example, I guess I'd say leadership, it's very hard to listen to able bodies telling us what we should be doing. And I think that I want to, we can obviously open up the floor for some questions, but I want to go back to some of the issues that were brought up about current therapies and why they're controversial, why we don't have a cure for spinal cord injury. Well, first of all, the first line of defense after spinal cord injury is to stabilize the cord. And I'm talking about from insurance standpoint, I'm talking from humane standpoint, is that they don't really necessarily want you to walk again. They want to stabilize your body so that you can do with as well as you can with what you have at that point in time after your incident, after your injury. So things that are commonly offered and prescribed are steroids. One in particular was methylprednisolone succinate, which was everywhere in North America, including Canada and United States, was being very well and utilized everywhere to prevent inflammation, to prevent the swelling of the spinal cord after an injury. And it was used widely for quite a while, but then there were some other anecdotes that started coming up saying, you know what, nobody's walking. And not only is nobody walking, but some people are getting sick from becoming immunosuppressed by these treatments. Now, on a personal level, I say that that's bogus, because if you got some kind of gastric ulceritis because of a medicine, you can cure that, but you can't cure spinal cord injury. So I think that the way, some of the steroids have been kind of shelved, if you will, and not used anymore, is a bit of a disservice to the community. And plus, I don't know how many of you guys were ever offered, hey, do you want a drug? Do you want to have, a hypothermic, do you want cooled down saline water to put into you? That's all the new kinds of therapies that are being tried, but those are never offered to patients. Those are more like doctor-decided questions. And then there's which obviously get mixed up with insurance reimbursements, or even litigious society that we live in. My doctor gave me this, or he didn't give me this, so I'm going to sue the heck out of him because I'm not walking. And then the next thing I wanted to just briefly touch on before we can open up is the stem cell issue. So stem cells, and Matthew and I've had discussions about this. I mean, stem cells are Pandora's box, because let's compare it even to methylprednisolone or any pharmacologic. You could put a pharmacologic at a certain dose at a certain amount, and you'll know about the pharmacokinetics, and you can actually take the person off the drug if it's not working, or if it's, God forbid, doing worse. You put in a biologic like a stem cell, you have no control. You being the recipient or the doctors have no control as to what that cell will become, whether it even becomes a functional neuron, or God forbid, a glioma, or a cancerous, a glial cell cancer that will basically kill you in the end run. And so the stem cell research is exciting, and I think it's because of the promise and the idea that we can put into a mature adult body that has been injured, we could put in these immature cells that will recapitulate, reorganize things the way we were when we were babies, sort of like a developmental process. But the problem with that is that, let's say it does work, and God, I really hope it works. You're not going to sit there like Homer Simpson, take these things and watch TV and hope to get better. You got to get active. You got to use it or lose it. And so if you don't use the stem cells, or you don't use the pharmacologics that are given to you, you're basically gonna maybe going uphill. Already you're going uphill, but a much more steeper incline than you normally would have had to, which is kind of like the last little tidbit that I'd like to discuss, is that in conjunction with stem cells or with FVS or epidurals, you have to be willing to exercise as much as you can. Now, I don't mean to say that a quadriplegic has any more or less work to do than a paraplegic. But if a quadriplegic, for instance, is going to get an implant to help move an arm or an extremity, upper extremity, they have to be willing to push that to the tilt, just as much as a person who's getting something for their legs has to be pushing that to the tilt. And that's where I think a problem is between the liaise, or the translation between basic science and translational science, what gets put to the clinic, is that, and this will be some of the dialogue hopefully Matt will pick up with, is that we aren't really listening to the consumers, we being researchers, or even NIH, National Institute of Health in the United States. They don't necessarily read, they almost like, here's what we think is best for you, and why don't you come into our trial and help us figure this out, which is a noble cause, and I think it's a very good cause. but it doesn't come back to the consumer, us, to say, well, what was that? Did it mean anything to me? Did it increase my quality of living? Or did it get your name on another paper and another grant? And that is very, very controversial because scientists, I personally am a professor. I have like 16 employees. If I don't have grant money, then, so am I always doing spinal cord cure work? No, I'm doing a lot of collaborative work and other kinds of conditions. But it always, for me, home base is coming back to how will I apply it in the spinal cord injury modeling and translational research. And then I won't go into it right now, but the exoskeletons I could talk about forever. They're wonderful. I've tried them myself. The problem is that they're not really going to be used for independent living. They're going to be used, at least at first, as I see it, as a way to try to rehabilitate you so that you can just increase your cardiovasculature, your musculature, but it's not going to help you walk again, at least not as I understand that they walk, or at least in my experiences. And then, I'm just looking at my notes, sorry. I think on that note, I'll kind of, let me last say this. I think that the biggest problem that we face as a community is, at least in the United States and Canada as well, to a certain extent, is the federal government and their approval of drugs. Because for any drug that comes up in any kind of lab, like myself, for it to go into clinical trials takes a lot of money. I'm talking millions and millions of dollars. And then to start the trials costs tens of millions of dollars. And let's say that the trial didn't make anybody worse, right, with drug X or cell X, but it didn't make them better. Well, then you have the problem of, well, why was it good? Do we even try it again? So I think that another thing that we held as a society in general, we have our bars set very high. We want the cure, but we don't want palliative cures. We don't want to fix this and we fix this. We want the whole caboose to be fixed, the engine, the caboose to be fixed. And that's kind of a misnomer. I've realized it. I've tried myself. It's just not going to happen that way. So, having said that, I think that if people in the community want to help, we, meaning organizations like Maths and Kentucky, we have to announce what is available to the community. But in so much, we also have the community to give us feedback. Because if we don't get feedback, we're talking to walls, basically. And I'm going to stop right there. I think I've talked enough.
That's awesome. There's a couple things that came up for me there, Sasha, so I'm just going to put it out there, and then hopefully, people have questions after that. So one thing I know John and I have talked about this before, and you kind of mentioned it, is in the acute setting, right? And then one of the things that we had talked about is the ethics behind that. So if there is a, potential treatment for someone who's an acute, what does that look like? And how do you, because I think a lot of people who have spinal cord injury basically would give away anything at that point to get better, right? I mean, right. Yeah. I spent 5 years of my life, trying to pretend I didn't have a spinal cord injury, so to speak, right? And right. Get to do whatever it took. So how do you sort of, I don't know, don't want to say get around ethics, but look at that and be ethical in an acute care setting?
From my experience, and this happened to me, the reason I'm going to base this on a story that just happened to me about a year ago. One of my best friends was my mentor, my spinal cord injury research mentor. His son was paralyzed, became a quadriplegic. And this just totally, his life changed, obviously his son's life changed, and Matthew, you can appreciate this, it just completely, your world becomes upside down. And one thing that they were just miffed by was that, and he's a researcher, so he was like, well, give him methylprednisolone, give him something. And unfortunately, in this litigious society we live in, doctors don't want to do anything except stabilize the environment in the cord. They kind of want to just say, all right, well, we can't make, the Hippocratic Oath, they don't want to make anything worse. Okay, that's understandable. But at the same time, if you pretty much know what the outcome is going to be if you don't do anything, to me, it does seem unethical to not try something, even an aspirin, for Christ's sake. I remember my father complaining that I wasn't even given an aspirin, after my accident. That was in 1985. And they didn't even have methylprednisolone back then. I was told methylprednisolone in 1990, oh, if you had that, you'd have been walking. Well, see, I mean, that's the kind of ethical thing that is the problem, is that you on one hand don't want to push something that you don't want to make promises with, but at the same time, I feel that too much is being withheld and not enough patient consent. I would love for my father to be able to say, hell yeah, put that in him. But that wasn't available, and that's not really the modus operandi in our clinical in our research. In our clinical enterprise, they don't really they ask for patient consent, but not necessarily to try an experimental drug, because they don't want to try an experimental drug because it's experimental, and that means litigious. That means that they have to have more insurance to pay for it. So I don't know if that really answered your question, Terry, but it's a very convoluted. And it is a fine line between the ethics of holding back versus pushing something that, like for instance, stem cells are us. You can go to Cambodia or you can go to Thailand. You can get all the stem cells you want. And by the way, you get 2 vials, it's half the price. So, I mean, and I'm not mocking it. I'm just saying that that's kind of scary to me in any capacity.
Thank you. Can you hear me?
Yes.
My phone's ringing. I'll stop in a second.
I just wanted to throw in a quick comment, maybe sort of a higher level response. And I feel like there's often an intersection between the personal and the systemic in this question. Obviously, as a father to a son with an injury, yes, would I have liked to entertain the possibility of some sort of intervention at that time to promote recovery for my son? Absolutely. Now, as an advocate, I look at this as a systemic problem in terms of where do we put our resources, where do we put our attention and focus in the larger research enterprise around providing recovery for the community, and where is it wise to do so? Sasha and I were actually talking earlier on an earlier call about some of the problems in the larger marketplace with trials that are focused on that early stage, where the marketplace has a very high demand for return on investment from venture capital that gets involved in drug discovery. And the process, as Sasha mentioned, with the government is elongated and slow to prove that it's safe. And so you have competing incentives that tend to, and we look back historically over the last decade or two, a lot of biotechs or a lot of companies that have tried to provide an intervention in the early stage, a neuroprotective strategy or of some sort, have died. They did not make it and they went bankrupt. And so those efforts were a failure. And to me, as an advocate, that raises a really fundamental question about how do we dispassionately analyze this so that we can have the most effect for our community, in spite of what my personal story may have been and what I might have wanted for my son.
Mm-hmm. Yeah, that's interesting. Thank you. Yeah, it's a hard question to ask, and and as a peer who goes into the hospitals, right? I feel like it's unethical for me to say, hey, did you hear about this? Although sometimes you want to, right? My other question to you, Sasha, was about the stem cells. So why is it that stem cells have just, why is it stem cells? Basically, it's basically gone out of control. People are making hundreds of thousands, millions of dollars off of stem cells. And why stem cells? And why not something else? I
think it's a very noble anthropomorphic desire to recapitulate developmental biology. So I know that sounded kind of long-winded. So you lose part of your spinal cord. You kind of want to just be able to reinsert the components of it, being the neurons and the glia and the myelin and all that stuff, and say, oh, look, well, if you put all that stuff back in there in an immature state, it'll be able to regrow and make connections. And there is much evidence to suggest that is possible. The problem is that, and what we forget as lay people, is that the spinal cord circuitry is extraordinarily complex. And that even if you were to fix a certain circuit, it doesn't mean that you're going to be getting your brain through that circuit to be able to make your foot wiggle or your toe move, or your hand flex. They're very, very complicated processes that go into even developmentally speaking. So the attraction, I believe, is that it's a replacement strategy almost. Oh, look, my parts are worn out. You know, even that's why even Alzheimer's people are starting to look at the stem cells to bring back neurons so they can remember things. And I dare not say that we have expiration dates per se, but we all, you know, we're human beings. We are not capable of doing things like amphibians, regenerating limbs and things of this nature. And so the idea, again, Teri, trying to wrap around, is to me, it's enigmatic, because I've done stem cell research and I've seen some completely opposite things that have happened, bad. And yet there are one or two prominent groups out there that show positive things. And that just leads this wave of other people following them. And I won't say they're Pied Pipers, but I worry about, well, if you're going to do the same thing and you get the same results, maybe you want to tweak it a little bit to get different results, to see that we're not making the same mistakes. But that doesn't give you the money and the research, because then you're doing something rogue and it's not as accepted. So I also think that, and this also comes from a pharmaceutical standpoint, biologics, which are stem cells, versus pharmaceuticals, which are drugs. Biologics are now outnumbering the amount of companies that are growing these cells versus a proven drug that has gone through years and years of scrutiny and drug dose testing and stuff like this. Now, pretty much it's, you want one or two vials, and you want to give it intrathecally or in your vein, intravenously in your veins, or into your spinal fluid. And we'll give you 2 shots at a pop. And guess what? While you're here, we'll also give you some rehabilitation. That to me is the worst thing, and I worry about how many people get involved with that, and they have bad things happen or nothing happens, but they don't report it, so that we as a community don't know the benefits. Because I've certainly, if there were people going over to China and we're getting stuff and they were walking, I think I would be interested, but I don't hear anything about these things except for 1 or 2 stories. So I dare say that along with the pharmaceuticals and the venture capitalists that we just discussed, I think a lot of this is financially driven, motivated, but not altogether unaltruistic. I think that people want to be able to create a biologic to replace things, but I think it's being done at a rapid race, which has outpaced, for instance, FES, or stimulation electrodes, or epidural stimulation, because these are modulating what's already there, not replacing or putting other things in. It's kind of saying, what do we have? How can we learn from tapping into systems that are still intact? Okay, whether we're quadriplegic or tetraplegic or hemiplegic for that matter, how can we tap into those? So I really believe, Teri, that the stem cell is a bit of a, it's a high-hanging fruit, but it's a bit of a misnomer that it's going to be a cure-all. It's going to be part of an equation to cure, but it will only be one step in that stone.
Yeah. And Matthew, hold on a second. I'm actually going to unmute everybody. So after Matthew, we'll just open it up. I think you've unmuted your, there you go. Yeah.
Thanks.
Yeah.
I just wanted to jump on. I very much appreciate the last thing you said, Sasha. And I think it's really instructive and important for people in the community to recognize that it certainly seems as if whatever intervention is going to promote recovery for people, it's certainly going to be a combination of several things, and not the least of which is the most basic and the most available right now, which is therapy and rehabilitation to augment whatever is intervened. I just wanted to say one thing, a little anecdote. I read a story this morning, came across my news feed in Vanity Fair magazine. Barbara Streisand has 2 dogs that were cloned from a dog of hers that died in South Korea. I think it's important because at the same time that we can't cure paralysis or provide any really meaningful treatment, a multi-millionaire can fly to South Korea with her dead dog and have them clone 2 puppies so she can have that dog back. You know, that's the world in which we live. And I actually think that also is is related. You know, you mentioned, Sasha, the anthropomorphization of sort of our aspirations, that we grew up believing that we were going to live in a Jetsons world, you know, where I would have a flying car and a robot, and, you know, and I think in part we do have this aspiration that when you see some of the promise of stem cells and regenerative strategies, you know, I think of, I don't know if any of you know, but I live in Minneapolis, Minnesota, and there was a researcher by the name of Doris Taylor here at the University of Minnesota. She took the cadaver of, I believe it was a rat heart. She washed all the cellular material out of it, like literally in the sink with like ivory dishwashing soap. She got rid of all the cellular material, and what you have is a collagen framework left, like the architecture of just collagen fiber. She set it up on this machine and dropped embryonic stem cells that were nudged to be cardiac muscle onto this heart. And sometime later, she connected it with vasculature, she shocked it, and it's a pumping, living heart muscle that she grew from stem cells. Now you look at that and you're like, shit, that's, wow. Now, the heart is a lot less complicated than the spinal cord. And she only had to grow certain kind of cells. But it's that sort of promise that sort of feeds into, oh, just squirt me up with a few million stem cells. You know, even though actually that's right now not going to do anything for you and may, you know, down the road harm you. But I just wanted to add that little.
Thank you. Yeah, so interesting. It's just like fascinating to me. Does anyone have, I've unmuted everybody, so if anybody has some questions for Sasha or even some comments to make, you may have muted yourself, but please chip in. Robert?
How do you get on a test subject list if you want to be that?
That's a very good question. For instance, just as an example, if you wanted to get the electro implants that I have at the Cleveland Case Western, it's relatively simple. You just contact them. I mean, simple in the sense that I'm telling you this now, but it's not really available. And that's the problem. Well, that's why we need to network, is that you go to their website and they actually have a link. Would you be interested in doing a clinical trial? You then click on it and see if you are eligible. And then you make contact with them, and then from there, they move forward. And the good thing about clinical trials, and this is why I did it back in 2002, is that they're free. I mean, all the care, all the standard of preparation, all the operations, they're free of charge because you are a clinical subject, which comes with a whole other set of caveats. Now, there is on NIH PubMed search, you could actually find all the trials that are going on in spinal cord injury in the United States. And in each of those, you can go to the link and it will actually tell you whether or not they are actively recruiting or whether these trials have ceased, or whether they are going to begin. And that's on nih.gov.trials/trials. And that's the United States. Now, I don't know about the Canadian. John, would you have any?
If you're looking for, clinical trials of that sort of ilk, things like FES implants or epidural stimulators or some of the stem cell trials that are going on, probably the best resource is clinicaltrials.gov. Again, it's a US government-based website, but pretty much any clinical trial that's happening anywhere in the world that has merit would be listed on that.
I would add one thing, Robert, to your question. The way you asked the question is suggestive of an effort that's afoot right now by a few different organizations to create a clinical trial matching site. And that would mean that any person could go in and say, my name is so-and-so, and I have a C5 Asia A injury, X number of years, blah, blah, blah. And you would upload that to this site, and then you would receive notifications about what trials that you would be eligible for, because currently that does not exist. You have to do all the, if you go to clinicaltrials.gov, which John is right, that's probably the clearinghouse, but you're going to scroll through pages and pages and pages of clinical trials. And so there's a lot of folks right now, as we speak, working on an effort to try to help make that more user-friendly, because it doesn't exist in that sense right now.
There are a few organizations, Matthew said, that are trying to look at that. So clinicaltrials.gov, it is very searchable. You can search for specific health conditions, specific areas of research in various regions. But again, it's not curated. It is just a clearinghouse. Anybody who fits the criteria that clinicaltrials.gov has can list the trial. So often there are trials that are based in developing countries that aren't really actually trials. They're looking for money to sell you a product. Do find their way on clinicaltrials.gov. As Matthew said, there's a couple of them. There's the Spinal Cord Injury Trials Toolbox, which is being developed by the Wings for Life organization in collaboration with some other funding agencies, as well as the Spinal Cord Injury Research Hub, which is just going to be launched in a couple of weeks' time, actually, in Australia, which again will give you an opportunity to register yourself as an individual with spinal cord injury and give permission for yourself to be contacted by researchers who are looking for participants. And again, I think as those become live websites, we'll certainly share that information with fantastic organizations like Spinal Cord Injury BC.
Go ahead, just don't forget to introduce yourself.
Yes, so my name is Matthew Roderick. I am the executive director of an organization called Unite to Fight Paralysis. We are a national US-based organization, not brick and mortar, kind of virtual. We have folks all over the country. We're a small organization, only about 6 employees, and the majority of them are part-time or contracted. Sasha, full disclosure, is one of our board members. We have board members both in Canada and the United States. The reason why I'm the executive director at Unite to Fight Paralysis is I'm father to a son who had a spinal cord injury back in 2008, a C5 injury, body surfing in Costa Rica on a student exchange program. And as Sasha mentioned, not unlike his mentor, turned our lives upside down, clearly. And additionally, our family was one of those families that once things were turned upside down, we kind of ran counter to the rest of our lives. I at the time was managing an emergency department, or was one of leadership in a management emergency department. I resigned from that position thanks to the grace of my wife. She supported me not getting an income or having an income for a number of years while my son and I traveled in search of therapies and recovery. And I began to educate myself, particularly about the science. And that really led me to become an advocate locally. And as I kind of grew those connections, I became involved with Unite to Fight Paralysis, and eventually they hired me on in a couple of roles. And then this past year asked me to be the executive director. Without going into too much detail, I guess I'll tell you really briefly what some of the things that we do. I would say fundamentally we exist. Everyone at U2FP is connected directly to a spinal cord injury, either has an injury or is a family member of a person with an injury, some immediate connection. We believe that's critical to our work because we believe that our work is somewhat unique in the sense that what we are trying to do is educate our community, our SCI community, people with the injury and their families about the larger research enterprise. And when I say that, I mean both science that's working to discover interventions, but that also means funding agencies, that means foundations, that means government like NIH and FDA. We want to educate people about that whole enterprise. On the other hand, we're also very committed to educating that scientific community and that research enterprise about us in the community. And we believe that that's a really critical piece. We're not interested in just promoting science or asking people to write checks to provide more research. What we believe is that we need to bring the scientific community and the SCI community together. So we do a symposium every year that Sasha mentioned earlier. It's going to be in Vancouver in October. We bring scientists that are leading the field together with community members. Usually our conferences are fairly well attended by people with spinal cord injuries and their loved ones. We also bring together some of the other stakeholders that I've mentioned, like NIH and the Nielsen Foundation. The Rick Hansen Institute is our title sponsor, and other entities, Christopher and Dana Reeve Foundation. They all come together at our symposium. We try to help unpack the science. And this year in particular, we're taking great pains to try to strategize about how can our community, how can people from the SCI community have an impact on this effort to provide curative interventions. So we do a number of other things. We have a scientific advisory board of volunteers who we offer as a service to foundations around the world. A lot of people from the spinal cord injury, you know them, the Walkabout Foundation and the Travis Roy Foundation and Perry Cross Foundation and the Hong Kong SCI Fund, people, families who have resources or actually are really good at raising money. They want to raise money for research, but they don't know where to put that money. So we put together scientists who review research proposals, and then we advise them on whether that's worth investing in or not worth investing in. We also have a podcast where we interview scientists. We interviewed Sasha a while back, along with a number of other scientists and advocates from around the world. We do a number of other things that are sort of all related to bringing the scientists and the community together. But I won't bore you with all that. I just want to say I'll add one little story, and then hopefully we can talk a little bit. When Sasha was talking earlier about how the scientists don't know, and I think you even said, Sasha, they draw a picture of what they think the community might want. I just have this, I've been having it in my head for a while. I have this image. Imagine you're putting together a puzzle, you know, one of those 1,000-piece puzzles, and you've got a big table and all the pieces are spread out. But imagine that that puzzle is upside down. And imagine that maybe when it was put together, somebody drew a picture on the back of that puzzle, on the you know, brownish cardboard, right? That's kind of what it's like. Right now, the puzzle's upside down, and the scientific community drew the picture that they think is the picture. And they are going piece by piece trying to put it together. Well, my belief is that we from the community are the picture, and we want to flip it over to say, no, 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 you're not doing a picture of flowers in a field. You're actually doing a picture of Princess Leia with a lightsaber, you know, get it right. And our job from the community is to tell that story to the scientists. And a great example would be for me, like right now, there's a lot of attention and even like hype around epidural stimulation and this neuromodulation strategy. And for decades now, really, that strategy has been driven by wanting to find, and I'm not disparaging any previous scientists, wanting to find a strategy to promote lower extremity function, leg movement, finding reflexive strategies that can be enhanced with neuromodulation by sort of amping up the signal of what's left. And what over time has been found is, well, wait a minute, some people are reporting autonomic changes, meaning in their blood pressure or bowel, bladder, sexual function, or temperature regulation. And then all of a sudden you have to ask yourself a question. Well, a study was done a number of years ago by my friend Kim Anderson to say, what do people in the SCI community, what's their priority? If you could take a pill today to get something back and you had to pick that one something, what would it be? And the reality is walking is not number one in any of those survey results. Doesn't mean for any person, it may be for some individuals, but most people in the SCI community want to be able to piss, shit, have sex and feel it, and have stability of some of those autonomic functions because they are the stuff of life. Like that's how life happens. You have to be able to do those things in a healthy way or you're gonna have real problems, not just with inconvenience, but even real health problems. So one way that the community can sort of change the dialogue and change the puzzle is to say, hey, wait a minute, why don't you stop focusing on this you know, really crazy high hanging fruit of using epidural stimulation to get everybody up and walking, when what really everybody wants is to do those basic things that will give independence of individuals' life back and quality. Back to the scientific community and say, hey, this is what we want, and how can we get there together? Because if you want us to participate in a clinical trial, then you better design some clinical trials that we would be willing to participate in and help move the field along further. So that's what we at U2FP, I think, are about. That's what we try to do. That's why I think our connection to the community is so strong because of our where we come from, but also what we want to do. We don't want to just throw more money at research. We don't want to just raise awareness. We want to bring these pieces together because we feel like it's in the bringing of those pieces together that we're going to get there faster.
Mm-hmm. And you guys do a lot of advocacy work as well, right? I always see on your newsletters, like.
Oh yeah, I guess. Sorry, one of the things that one of the tactics, I guess I would say, and maybe even part of the reason why I was considered for this position, is I started some years ago to pursue a legislative effort in the state of Minnesota where I live to fund research for spinal cord injury cures. And so we passed legislation. It's a $6 million appropriation to go into research. But what I learned along the way over years of doing this was I started by thinking we just need more money to the research. but that was a long time ago. That was 2010 when I started thinking that way. Along the way, I realized, oh, no. That's not, we don't just need more money. What we need is smart money, and we need informed money. And we need from the community to be able to leverage that money. So between 2010 and now, what we have done is we put community members on advisory boards along with scientists to decide with equal vote what we're going to fund. And it's in that process that the community now is talking with the scientists, has actually cultivated relationships with the scientists, and push back on the scientists to say, wait a minute, you said if we invest in this stem cell study in rats that we're going to change the face of medicine. And I say back to them, that's BS. You're just trying to oversell your study on using stem cells in rats. So no, we're not going to fund that. And it's those kinds of conversations that have, I think, accelerated some of the research that's happening here in Minnesota. And so as a result, Unite to Fight Paralysis is now working in 4 other states in the United States to pass legislation that would do the same thing. Put people in the community into the same room with scientists, leveraging money to leverage research. And so we passed legislation in the state of Washington. Now we're working in Wisconsin, Pennsylvania, and Ohio, and looking eventually, once we have more capacity, to expand into other parts of the country.
I think, Matt, may I quickly? I think Matthew touched on a huge point there. And Sasha, I know you're a professor and a researcher, so I'm going to harp down on researchers a little bit. I don't mean to target you here. Generally speaking, researchers tend to work in isolation a lot. You know, they work at universities, and their tenure and their career are dependent on how much they publish and how much they bring in grant money. And, you know, we recognize that that is what really matters to them. But we need them to recognize that what really matters to us is improvements in our lives. And so what we need to do is nudge them. I wouldn't say force them, but certainly nudge them to work in more collaborative ways to come and try to achieve outcomes that make a difference and have an impact on people's lives, and don't just become a really nice publication. And so really, I think that's where the consumer perspective, the experience of people living with spinal cord injury, can bring that conversation around to, that's really great that you're doing something in a rat model. What is it going to make, how's that going to make a difference to my life? If you want us to spend our money to get behind your work, to get involved in your research, you know, it better make an impact on my life. There's only so many research dollars to go around. And if I can find any way to get an influence over where those dollars go, I will. And if you're just going to create a study that's going to create a nice publication that's going to look really great for your tenure track, that's not going to work for me.
You know, I would thanks, John. I would add, just to go back to my puzzle image, 2 things, and especially not to disparage scientists in general. And I don't think you were, John, but if we look back at that puzzle thing, I think one thing, and to preface it by saying how important proximity is to everything. You know, everything in your life is, your worldview is determined by what you are closest to. You know, I do what I do because of my son. That's why I'm an advocate for spinal cord injury. If my son had gotten cancer, I'd be probably doing that. Or if my son was a professional soccer player, I'd be obsessed with soccer. It's about proximity. And so as it relates to that, what happens with scientists using the puzzle image is they get obsessed with that piece. that they're working on. They're working on one puzzle piece or maybe two puzzle pieces, and that becomes their obsession because that's what they're proximal to. And they're trying to find, where does this piece or these two pieces fit together into the puzzle? And so they get consumed by that piece, and that becomes everything. But the other thing we have to remember is that they've got somebody behind them, a boss, that provides incentives for them. It might be a dean of research, it might be the institution itself, it might be whoever's running the department at a university, or if it's in pharma, R&D, someone is telling them what they have to do and what's important, and what their incentives are, like publishing, like getting grants, like their tenure track, or even like their career. I mean, scientists do make a career out of answering certain fundamental questions because they're so difficult to answer. Our job is to, like you said, is to nudge and remind them, what does this puzzle piece mean? What's the implication of that puzzle piece? It doesn't mean we're going to badger them and berate them for focusing on that puzzle piece, but it's to remind them of the big picture. And there are ways to do that. Some scientists, in my experience, there have been a few, bristle at that. When I nudge at them or I make a comment or a suggestion about why are you doing this or why are you doing that? Or I wouldn't be interested in funding that, or why do you not have a different kind of model for that study? But there are plenty of other scientists who want to find something meaningful. They don't want to spend 40 years doing something that had no impact on the rest of the world or didn't teach us anything to unpack the complexities of the spinal cord. They want to find it just like we do.
Mm-hmm.
But and that's where we can work together, I think, to nudge one another. They can nudge back to us to say, you're being naive about what you expect from this line of discovery. And we can push back on them and say, well, where are you going next? Are you asking yourself that question, or are you just answering a question because for the sake of the question?
Matthew, in your community members that are part of sort of those discussions, do they have, what kind of background in research do they have? Like, sometimes talking to researchers can be difficult in itself. So I imagine there needs to be some kind of knowledge translation there.
Yeah, well, so when you say our community, what do you mean?
Well, you said like in, your state, for example, you have like community members that sort of go in and have discussions with the researchers themselves.
Right. So what I would say is, over time in our community, I'd use myself as an example. I'm a layperson. I do not have a science degree. I do not have a background in science. I did have some background in healthcare, but not clinical. I pursued a lot myself. I did a lot of study, a lot of reading, a lot of conversations with scientists, with clinicians. So some of us are sort of self-trained in the sense that not that I can claim that I know anything or I have the expertise, but enough that I can speak a language. And that in turn, when I don't understand things, I either ask or I go find out so that I can understand what was being explained to me. That's part of what our symposium is about. That was probably my first intersection with really being able to start to unpack the science. Sitting through our symposium, which is historically fairly science heavy, is a challenge. But I kept coming back and I would keep studying in preparation for that symposium so I could learn and speak the language at least enough to not sound like an idiot and grow a little more in my understanding. there are, over time, like our community in Minnesota, so I sit on that advisory board. My friend Rob Woodlick is like me. He has an injury. He started to dig into the science and learn as much as he could. Now, in a couple of instances, like one of the advisory board members is a guy named Dr. Peter Grahn. He's at the Mayo Clinic. He is a scientist, but he also has a spinal cord injury. And so he's a great asset on that advisory board because he's in both worlds. And then we have a couple of family members, either aunts and uncles or wives and husbands who actually work in the sciences, in the science field. One woman who's works for a small pharma company, and she comes out of biomedical research. She's a great asset in having those kinds of conversations. And I think that's something that just unfolds when you do this kind of community organizing and social movement organizing. You just start to widen the net of people, and you start finding people that have shared interest. And then you discover, oh, you work for Medtronic, or, oh, you work for this pharma company. We could really use your knowledge and your expertise. And that's kind of how it's unfolded in Minnesota. And to some degree, it's also seems to be working that way in Pennsylvania, Ohio, and Wisconsin.
So, Matthew, if I can just carry on that train of thought for a second. You know, I think one of the things that we've been talking about is research and the perspective of people living with spinal cord injury, and how we're trying to bring that perspective into the researchers' train of thoughts a lot more, and trying to have an influence on what happens. So, as an individual, all of you that are here with us today, as individuals with spinal cord injury or some very close direct connection to spinal cord injury, you're experts in spinal cord injury and living with a spinal cord injury. Researchers, on the other hand, are experts at the science of trying to improve lives of people with spinal cord injuries. What we need to do is find a way to bring ourselves together. We need to teach researchers to incorporate our perspectives in the research. But at the other point, we can't just sit back and say, come to us. We need to step forward and come to them. We need to start to understand what they understand, the science, so that we can have, as Matthew said, an understanding and have that conversation, and be able to not sound like you're an idiot. You need to know what you're talking about. You need to be able to speak their language as much as they need to be able to speak our language. So if I may, because I've only got a few minutes left before I need to run, I'm going to share my screen again for a couple of seconds, if that's okay, Teri.
Yes. Mute myself.
And talk to you guys a little bit about knowledge translation. Knowledge translation is as simple as this. It's how do you share information? How do you get knowledge that's generated and share it with people who don't yet have it? It's going to school, that's knowledge translation. So if you want to go to school, here's a great place to start. This is called Don't Call It a Miracle, The Movement to Cure Spinal Cord Injury by Kate Willett. Very smart woman whose husband has a spinal cord injury. She attends Working to Walk every year, and she live blogs from it and shares with the world what's happening there to those who aren't able to attend. You know, get educated, understand the science. This is a great book written in everyday language. It's available for free on the Christopher and Dana Reeve website, and it will help you to understand the biology. It'll help you to understand the history of the research into it, why it's not going as quickly as we would like to, and what you can do to get involved and move forward. As we mentioned a few times, Unite to Fight Paralysis, Matthew's organization, they have a podcast called the CureCast, and Matthew has access to some of the smartest individuals around the world on all sides of that spectrum, from regulatory to research to funders to individuals with spinal cord injury, and he interviews them and has great conversations with them. If you want to hear from various perspectives about what's going on, just search out Unite to Fight Paralysis Curecast. It'll take you to the website. I think you're up over 20 odd episodes now, if I remember correctly, Nati, and they're fantastic. Working to Walk. This is coming to Vancouver. It'll be here in October. We're having it at the Sheraton Vancouver Airport in Richmond. Again, this will give you an opportunity to sit and listen to the researchers, to talk to the researchers, to challenge the researchers, to learn about the science. Rick Hansen Institute is really proud to be sponsoring this event. And I'm sure if you contact myself or Teri, we can give you more information about the actual symposium and how to get there. Subsequent to the Working to Walk conference is the second annual meeting of the North American SCI Consortium. Sasha said he was going to talk about it, but he decided not to, so I'll get in a little bit about it. This concept is born of people living with spinal cord injury, where the idea is alone our voice is small, together our voice is loud. And so this is a consortium of consumer organizations and individuals who are focused on advancing the science of spinal cord injury research. We're having our meeting the day after Working to Walk. If you're interested, go to the website. You can learn more about why we were created and what we're trying to achieve. And we welcome you if you want to be a member and want to come and join us at our meeting. The door is always open. And if you find that getting to Working to Walk or the NASCIC meeting might be a bit of a challenge for you, there are travel grants available. Through the Rick Hansen Institute, we were in negotiations with Spinal Cord Injury BC and other spinal cord injury organizations across Canada to provide funding for individuals who want to attend the conference. And I believe Working to Walk has its own opportunities for travel sponsorship for people who are unable to attend due to financial constraints. So,
John, can I jump in there for a sec?
Yeah.
Yeah, just to add to that for those, you know, and you can pass it along to your friends as well. We work very hard to keep the conference accessible to the community. So the fee for the conference is relative to conferences like it, very inexpensive. But for those who have a spinal cord injury, it's half that price. And for those who need a caregiver to go with them, the caregiver goes free. They don't pay a registration cost. And we also do have limited, but usually enough to cover quite a few people. We do have travel grants. We do request that people apply for that, and we have a series of questions that we ask. But all of that is driven by the fact that we truly are committed to making sure that the community comes. It's meaningless without that. So.
Thank you.
So can I chime in?
Yeah, please, Sasha. Yeah.
Okay, so yes, I woefully did not talk about NASCIC. Sorry, John. So I was writing down notes here as I was listening, and I think that in speaking to the members of Robert and Jeff and people who I don't know for the first time we're meeting, I want to make sure this is kind of clear after we hang up and whatnot. There are lots of forums, there are lots of blogs, there are a lot of discussions like this where people kind of, you do it and then you leave and you kind of, you know, didn't get your answer or you weren't satisfied. And I think the common message I would like to kind of convey from this, from all aspects of the people, from Matt to John, is that we all have the common mission, but the common mission and the goals all depend on individuals like yourselves who are listening right now. And that's that we're not asking you for necessarily new ideas to come up with new infrastructures or ways to pay grants or a way to develop new ideas. We're asking, okay, if there are these groups that we're introducing you to or studies that you can get involved with, start asking questions, get on a line, start being pests. Because unfortunately, and I deal with a lot of organizations, hurting anybody, any kind of group together is hard. Hurting people with spinal cord injuries is even harder. It's like hurting cats. And that's what the NASCIC is all about, is to say we have all these silos all across North America, whether it's in Canada or with this Christopher Reeve problem, yet somehow we don't communicate. We all like to wear our own badges of honor and stuff like this and claim responsibility. But what's our mission is to make lives better. So I'm not being a preacher here. I'm just trying to convey that I'm not hearing a lot of questions, which is fine, it's normal, but I want maybe you to be writing down and thinking of questions that when you do reach out, that you can ask. And certainly call me, email me afterwards on a personal note if you want, things that weren't able to be discussed. Or Matt, I would even open up Matt's, he hasn't said it, but I would open up for him as well, because it's feedback from consumers, which is what we're trying to get across to the research community and the clinical community. Why would anybody be doing Parkinson's research if it weren't for Michael J. Fox, right? Now, admittedly, it's a more devastating condition as far as its fatality and things of this nature, but that doesn't mean that we can't have a collective voice. And so without, again, preaching too much, I think that the mission from this kind of a group, and hopefully it just keeps expanding with the NASCIC, the consortium, is that people start to interact and ask questions which then directly go back to the clinicians and the basic scientists to say, stop, we're not going to fund you, because the people that are asking to be funded, they don't want this to be done. And it's not a democratically decided decision. It's more of a oligarchy right now. And we can't have that. So anyway, that's I wanted to end with that 2 bits right there.
Thank you. And this is kind of to that, Sasha, also, and Matthew touched on it too, is we're talking about sort of the proximity of spinal cord injury, right? And giving feedback, right? And how important that is. And I'm just thinking, like, we obviously have our own personal experience and have our own personal desire for what research gets done, right? So when you are giving feedback, it's going to be very personal. So how does that affect that researcher? Like, how is that meaningful? Because it could just come across as being, well, it's just one person. Like, there are many people who this is gonna, be important for.
On a personal note, like for instance, in my laboratory, I have several research projects going on, but I make sure my students and my postdocs or my research associates, if they don't have at least an elevator pitch to anybody up on the street as to what they're doing, they should not be doing the work, because they have to understand why they're doing their model. Yes, it may not be globally recognized, it may not even be accepted as it, but there's got to be a reason. And so I honestly, and I struggle this with myself, why would I do certain research when I go out to the community? How is that going to help the people? Well, it may not help them tomorrow, but it's the foundation upon which 2 more people ask a similar question and you have a consortium. So I don't know if that touches Teri exactly, but that's my sentiment.
I'd like to throw a little something into that. 2 things. One, I've had a number of scientists either come up to me or respond to me when I've told a couple of stories and thanked me or said to me, I hadn't thought of that, or I wasn't aware of that until you said it to me. And I'm always like, God, how did you not know that? But again, you remember proximity. Like you just don't see
right.
What all the things I'd never seen, I would never imagine prior to my son's injury, right? And part of why that's so important is because here's another, and I don't know if Canada is different from the United States, but one of the things I've found in these years of sort of trying to mobilize and organize people from our community is that they're reticent to tell their story. And in particular, they're reticent to talk about the dirty bits, talk about bowel, bladder, sexual function, because it's uncomfortable for a lot of people. It's generally, here's a fact, just in case for those of you who know, and I wasn't aware of it until this year as we're planning our symposium. Guess what there's almost zero research on in the world with spinal cord injury? If you were to isolate one function, guess which one it is?
I guess it's sexual health.
That's exactly right, sexual function. And guess why it's not being researched?
Because no one talks about it.
Well, but also why?
Oh.
Because
No
people
one
with
is willing to
disabilities
fund
don't
it.
have sex.
No one is willing to fund it.
Huh?
The funding organizations don't fund it because they're scared of what that might look like on their profile. That they're funding, getting an erection or getting wet for women, or getting to an orgasm. I mean, how ridiculous and provincial is that? That the reason why that's not being funded is because we're too puritanistic to talk about it. And so the reason why I bring that up is that the onus is not on anybody else but us. We in the community have to then talk about it and say, hey, wait a minute, this is what we want. Why are you not funding that? Why are you not researching that? So we have to tell our story. And when we tell our story, there aren't many better out there, when it comes relatively speaking. And then lastly, I would say this. I got a message, an email a few months ago, and I think Sasha knows this, he saw it. I got a message from a scientist after writing a newsletter, and it was telling a story. And I know this guy more personally, and I respect him. But he basically said to me in the message, he said, thank you for the message. It reminded me what I'm here for. And he said, after a day or a week or whatever of, I have to teach classes and I have to write a grant and I have to go to these meetings. And, these people are like chief executive officers of a laboratory. He said, your story reminded me what I'm here to do. So I came back to my lab and I worked till 3 a.m. On some of the experiments that we have going. And he said, thank you, because it just reminded me of what were the big picture. And that felt so good, because here was a direct example of where you're telling a story that sort of pushes on a scientist to say, oh yeah, I forgot what I'm here for, and I should spend a little time doing that. I mean, that's what we can do if we tell our story. But we got to tell our story.
Thank you.
Absolutely. Anyways, guys, I'm going to have to say goodbye because I got to run to an appointment. If you have any further questions for me, or you're interested in any of that information that we've been talking about today, reach out to Teri and she'll get in touch with me and we'll pass it back on to you. Anyways, I hope to see you guys at the Working to Walk conference in October. And thanks, everybody. I'll catch up with you guys again soon, hopefully. Bye.
Thanks, John. See ya.
All right, bye, John.
Does anyone have some more questions or comments or anything?
Yes.
Go ahead, Robert.
Yeah, well, this might be considered collective. Not everybody that has spinal cord injury has exclusive claim to certain difficulties, health problems. Mm-hmm. So my question is, and this is the collective part, things that don't just have an effect on spinal cord injury. For example, say neuropathy. Many peers do have that, but many non-peers have that also. Now, what I'm seeing on the internet a lot online is a lot of marketing by doctor-backed institutions that have all these supplements that they're promoting. as working wonderfully for neuropathy or for mental acuity, and the list goes on and on. It's all usually aging related. Now, since you're a scientist there, Sasha, I'd like to know what your insights are on that. Whether it's that's something that you just avoid, or maybe it might be worth looking into. I'm not going to hold you to it. I'm just going to like to know your insights, if you have any.
I guess it was a loaded question. Could you rephrase it?
Oh, yeah. It's not all peers have an exclusive claim to certain afflictions. Neuropathy, for example.
Okay.
Mental acuity, all these things that are a normal part of aging. There's all these doctors online doctor-backed institutions that are saying, oh yeah, we've developed this cutting-edge supplement that will erase your neuropathy, your mental acuity issues, and there's just so many aspects, and it all sounds wonderful. Sounds like all these natural biocures, not pharmacological, but biological cures. Or not cures, but just supplements that work, they say.
Right.
And I'm just wondering if that's a big scam, a huge scam movement, doctor-backed, or not. I know that you wouldn't know per se, but your opinion.
Yeah. Well, I will say, I will share this. I get probably a dozen calls a week from people showing me, either asking me about an article or about a cure or about a stem cell trial or things of that nature. And I almost have a form response that I could maybe send you, which it doesn't demean the message, which is that you have to be the worst critic, and you have to be willing to ask the tough questions, because doctors they're human beings. They have to be held accountable. And if you don't feel that you're necessarily could approach these people, well, the first line is, I'd say, call me. I may not know the person, but I have no problems with looking up their email address or their website and asking them questions. And I'm in no way am I professing that I know better. I just know what questions to ask. And I certainly can smell a skunk when there's a skunk. And 9 times out of 10, I will find and act on behalf of the person who's inquiring. We'll get on a conference call. Halfway in the conversation, the guy realizes not necessarily who I am, but what I'm saying, and he just completely backs out of it. So I think there's a lot of what you're saying is there. Look, money makes the world go round. And in the medical field, unfortunately, what people do is they prey on the people who are willing to either pay or sacrifice their livelihoods so that they can get a cure, if not for themselves and for their kids. And so I would just say, with any of those, just like anything I see on a commercial ads for politicians, you have to take it with a grain of salt and do a little bit. I'm not saying a lot, a little bit of homework by reaching out to 1 or 2 contacts that you would feel comfortable. Now you've met one virtually that would feel comfortable helping you assess whether or not you thought that was bogus or not.
Right. Yeah, great points. Thanks.
Thank you. Anybody else have anything to say? Question?
I do, Teri. It's Guy.
Go ahead. Yeah.
Will you have Sasha's and Matthew's email addresses and whatnot?
I do.
Sasha, I work with Spinal Cord Injury Alberta, and oftentimes in the new injuries and family members are almost, I'll use the word, desperate to find the cure and do whatever they can in regard to stem cell. And for us to, and I've been injured 35 years, to sit back and say, carefully look into it. Maybe you don't want to spend all this money and go to Thailand or China and, do a little bit more in-depth research about stem cell and possible side effects.
Mm-hmm.
Would you be open to having family members email you, contact you as a resource?
Sure, with the understanding I'm not a physician. I want to make that very clear, because a lot of times they call and I have to really explain that I'm not a physician, a licensed physician, but then I do give them my background and it gives them a different perspective. And then what I typically do is, as you alluded to, I will then guide them. I won't necessarily advocate for them, but I'll guide them. And then even more so, if you don't get a response, or I've even said, when you get a response from that person, I would like to see it. Would you mind sharing? They'll share it with me, and then I'll get back. I said, this is hogwash. This guy's full of bunk. Or, you know what? I think they're legit. I think you should maybe look into this. So no, I don't have a problem at all. Once Teri sends me my contact information, I just don't know how quickly I can respond, but I will respond.
Guy, I would say the same thing. Obviously, I'm not a scientist, so I don't have the credibility or expertise that Sasha does. But I didn't let you all know that I did take my son to India in the early days, 2009. Spent lots of money for stem cell treatments twice. We lived there for several months, came home for a couple, went back again. And it was in that process that I really began to study and unpack. And I was one of those parents. We were one of those families that, looked at all of Western medicine as a conspiracy.
Mm-hmm.
This was on the heels of George W. Bush putting a moratorium on embryonic stem cell research, and thinking, well, we're going to have to get out of here to go find, the real cures. But years and years later, now I understand what it was that we did. I understand, and I'm grateful that my son did not have any adverse side effects. But I understand now what was going on. So I would be happy to share. And again, I get those same kinds of messages. I actually, interestingly, just replied yesterday to a gentleman whose son wants to go to Thailand to get an epidural stimulator implanted, and is considering adding the $60,000 to get stem cells. And I asked him to send me what they sent him. And I read through the 6 scientific publications that they sent this guy, and I have enough knowledge to be able to tell him, look, every single one of them said, there's so much promise, but there's so much we have to study yet. And so how disingenuous is this place to say, give us $60,000 for some unproven science? That's risky.
Mm-hmm.
And so I'd be happy to talk to people with the same caveats. I'm not an expert. I can share my story and really encourage people to think really critically, and to pause that desperation just enough to take a breath and think about what you're doing. And actually, the other thing I would add to that is, and it's something Sasha said earlier, if you're going to do something like that, or you're willing to take a risk on behalf of everyone and get into a clinical trial. Because then at least you're taking a risk that is being studied and measured and regulated, as opposed to spending $100,000 on something you just have and you can have no idea what they're putting in you. And trust me, I was a pain in the ass to those people in India every minute. And I still can't tell you exactly, that I know exactly what was going on. So.
Interesting.
Oh, thank you. I know it's there's a fine line between squashing somebody's hope and keeping their hopes alive for that, whatever they believe is a cure in their mind. So as someone working with spinal cord injury, Alberta, you want to keep that hope alive, but you want it to be a a realistic hope and an educated, calculation on their part. And,
Yeah.
I think that participating in the clinical trials that are measured is maybe a good way of phrasing it, so they're a little more aware.
Yeah, you said it very well, Guy. I remember a couple of years ago being at a conference. My friend Barry Monroe, who's in Toronto, brought me to in Toronto, and one of the scientists there, I won't tell you his name, said he was commending my friend Barry, who's, I don't know if any of you know him. He's been injured 36 years, runs Canadian Spinal Research Organization. He was thanking Barry and said, it's so important because we are here to give hope to the community. And I interrupted him and I said, hope is a dangerous word. I don't think you're here to give us hope. I think you're here to research towards an outcome. I don't care about you. Let us handle the hope side of things. You have a different job, and it's not peddling hope. But you're right to point out, there is a delicate balance to be struck in how we talk about, particularly people when the injury has just happened. It's devastating.
Yeah. Thank you, guys. Anybody else in there in the little?
Yeah, sure.
Yeah, go ahead, Robert.
Yeah, Matthew. Yeah, I agree that all of your points. I think that you're saying, one of you was saying that either Sasha or Matthew, that of the silos of information that peers are, and you're right, they are silent silos. And I think that's the satanic language. I think that's where we all lose because we're not forthcoming. It's maybe embarrassing or personal, and I think we have to outgrow that. I think that's part of getting off the couch is being interested enough to sacrifice your own privacy and express. And I think, Matthew, that your credentials are high. You said you're a lay person and not really qualified, but you are more qualified because you're not conditioned by a bunch of useless education. Not that education is useless, it's not. But I'm saying that it can be very, it can be a problem. And you sidestep all that, and I really value your input here. It's been excellent. Thank you.
Thanks, Robert. It just occurred to me, one thing that you said reminded me of something I was going to mention earlier. I think John put care and cure up there. And I know historically, for those who've been around a while, fortunately, I haven't been around long enough to sort of be in the deep trenches. There was a divide of care and cure. There's people that don't talk to me about a cure. I'm only interested in job creation and resources and ramps and curb cutouts. And then the more militant cure folks saying, stop wasting your money on that stuff. As my son calls it, stop fighting the fires and find the person with the match. Whereas what I see, and I think what is happening increasingly now, is they're on the same continuum. Care and cure are on the same line. There is no debate. But back to your point, Robert, about silence, unfortunately, historically, what that has led to is this sort of happy cripple, that the messaging that has dominated, I think, particularly in social media, is look at me jumping out of a plane, and look at me skiing, and look at me doing, everything's great. I'm fine, And that's, I'm not suggesting that someone is necessarily being disingenuous. That doesn't mean that you can't be happy with a spinal cord injury and do all those things that some people do. That's true. But the fact that what isn't ever told, and particularly told to the able-bodied community like me, is what it took to do that. You know, and it reminded me of a story I know I told Teri and John, of my friend who plays quad rugby. And he told me a story a few years ago that sort of opened my mind. I mean, I knew it from my own experience with my son, but he said, you know, every quad rugby tournament it's dominated by three things. One, you have multiple people sharing a hotel room, and their bowel programs and coordinating them would require a PhD. And then two, everything is interrupted by the bladder, because either somebody's leg bag burst, or their condom fell off, or they have to stop to cath, or they got wet. And then he said, and then when the games are over, everybody's at the bar talking about sex, how they have sex, how they want to have sex, how they're going to try to get sex tonight. And he said, everything is dominated by bowel, bladder, and sexual function. So he said, if the community could just recognize that, and recognize that, of course you can be happy and live, you know, a fulfilling life, but tell the story. You know, tell the story so that people understand I can do these things, but it means I got to do them with some challenges, or with some work and some certainly thought. Like my son always says, like, it's like a part-time job just managing, you know, all the stuff I have to order and do, and my PCAs and what have you. Like, yeah, I can do what I love to do. And my son does it. He's a musician and a singer, gigs a lot. He's doing what he loves, but he has to do a lot of stuff to make that happen. So yeah, that silence is critical.
Mm-hmm. We got 4 minutes left. Anybody have any other little comment?
Question, Teri.
Yeah, go ahead, John.
My question is, I'm a little different. I don't have a spinal cord injury per se. I have a spinal cord cyst. So when it comes to studies, they do a full interview. I get through every facet of the interview. However, I get dumped because I have a cyst. Oh, wow. You know, but I have all the same symptoms.
Is it progressive?
Yes, it is.
It is. And how long have you been, without going into too much detail, how long have you been pursuing getting help with this?
Right from 16 years ago.
Wow, that long.
Yeah.
And it's because it wasn't traumatic? That's the reason?
Yes, exactly.
Yeah, that's
what everybody says.
No, I don't mean to mock it.
No.
It seems to me that because I actually have a friend who has had cancer, and he started to impinge on his cord, and he also started to get, and a very similar thing started to occur to them, that they were more worried about the cancer than they were about his paralysis, but he was more worried about the paralysis. Mm-hmm. So I really, gosh, I don't know what to. So I mean, when you say they kick you out, you mean you've been trying to get into trials, but they say that you're not qualified?
I don't qualify because I didn't have a traumatic injury. My cyst was progressively gets worse and worse and worse.
Mm-hmm. Wow. I guess, so are there particular trials you've been trying to get into that you could maybe, you'll get my email address, maybe we could talk a little bit more, and okay. I can help investigate that, because if there are particular ones.
I know it's a can of worms.
Yeah, well,
yeah, but
the thing is that this is the conundrum about the spinal cord injury community, is that we are an orphan condition. We're not, and in your case, it is a neurodegenerative condition because it's progressing, whereas with spinal cord injury, once you're spinal cord injured, you're pretty much, that's it. You're stabilized. Once they get a tube and you can catheterize. It's different in your case, and I think that's why maybe there isn't so much of a, it is a slippery slope, unfortunately. Let's keep up, Jeff. Let's go ahead and correspond with this, and maybe I can help you out on an individual basis, because I really have not been able to advocate for individuals as yourself who are not like in it for life because of an accident when they were young. Sounds to me for 16 years is getting worse and worse, and you're still not getting any kind of help. And I guess the question is that can they attack the cyst versus because you have a situation in which you have a pathology, but that secondarily you're having complications with spinal cord injury. Is there a reason why they're not going after the cyst? I know, that kind of thing.
Oh, you're on mute, Jeff. Jeff, you're on mute. Can't hear you. You have to unmute yourself. I don't have you on mute. Hold on, let's see if I can. No, somehow you unmuted yourself. I can't unmute you.
Okay. Well, if you can hear me, Jeff, go ahead and email me that, and we'll keep it. We'll keep up that.
I was just gonna like finish up on that. We do, at Spinal Cord Injury BC, we don't just have people with spinal cord injuries, right? We have people with other disabilities too. And I do research recruitment as part of my job there. So when I send out the recruitment information, I know I get a lot of feedback from people with other disabilities saying, they won't take me, even though this affects me. They're not going to take me because I have spina bifida or I have CP or whatever. There are a multitude of reasons, right? But it still affects me. So how can I, express that? How can I get help too? So it's, I think, a more common problem.
Yeah, Teri, I was just going to add, almost every year at our Working to Walk symposium, I will have a conversation with someone who's from, has the effects of a spinal cord injury, but it's spinal muscular atrophy or, a spinal stroke or, different etiology, whether a medical condition or a different kind of injury. And it's and Jeff, it's kind of the same story. Their experience is very similar. At least with SMA, there are some organizations specific to that disorder, but it's complicated in that it's already a small.
Oh, Matthew cut out again. Matthew got killed. Oh well. On that note, Sasha, do you know what he was saying? Could you finish up?
No.
Well, I'll have to leave it at there. Maybe he'll come back on, but yeah, we will. Thank you everybody so much for your great questions, and thank you Sasha and Matthew and John, and I will get out this information to everybody so you can continue these conversations further. I think it's been really helpful and informative. So I know for me, I hope that you guys will consider going to Working to Walk and the annual meeting. The NASCIC meeting, Sasha, do you need to be a member to attend first?
You do not. What I can do is I have a new link because membership is now free, by the way, for NASCIC. We've waived membership fees for the first year because we've got some financial support. And in the same link I could send out has also a registration for the meeting, and you do not have to be a member.
Yeah, that'd be great. So if anybody wants to, is interested in learning more, I really would like to stress, first of all, like reading that book. It was very informative for me and helped me in my sort of education in this research community. And also attending Working to Walk. I fought it for years and years and years. I was like, I'm never going to go to conference that's called Working to Walk. Never.
Yeah.
Then I met John, and he kind of made me go, and I actually really enjoyed it. And it was, I'm not gonna lie, it was difficult for me at first to be able to like kind of understand, but it was really great to just see what's new, what's happening, what's exciting, meet other people and see how involved the community is. I hope that this is the first time they're coming to Canada. So that's really exciting in itself. And I'd love to see a bigger spinal cord injury community represented at this one than I did see in Miami. That would be awesome.
Although Canada was very well represented in Miami, I have to say.
Yeah, they were, definitely. I do agree with that. Yeah. And then the consortium too, I think, is like another step of just being able to stay connected to what's happening. And if you're interested in research, these are super great opportunities to like keep up the knowledge. So and become like your own advocate, right? So I see Matthew just joined us by phone, so you cut out. Sorry.
Yeah, no worries. It was all me. I wasn't paying attention to my laptop and it died. So.
Anyways, so just saying thank you to everybody, and and we will we'll see you guys in the fall for sure. So
thanks so much for having me, Teri. I appreciate it. And to everybody on, feel free when Teri shares contact information, reach out if you like. Love to hear from you.
Awesome.
Ditto.
Awesome. Oh, and Matthew, too, the Working to Walk, I just wanted to also mention, if you are interested in participating and you're a person with spinal cord injury, you do have to like send an email. So before you go through the whole registration process, there is a bit of a line that will say if you're a person with spinal cord injury, then just to email one of Matthew's coworkers there at Unite Fight Paralysis, and he'll give you a special code where then you can register. So
okay.
Yeah, and that's for you. And also we'll ask you if you do have a caregiver that wants to attend, we'll ask for their name so that we can give them a code so they can go free. And then for the person with a spinal cord injury, 50% off the registration cost.
Yeah, for the whole weekend. So, and like for people like Jeff and Heather that don't, live in Vancouver, if you're interested in attending, please like let me know, and I can try to get like a, put you through to where the travel grants are available, and be awesome to see everybody there. Great. Well, thank you everybody so much, and we'll see you next month.